Can everybody see my screen?
Yes.
Okay, thank you. Right, good afternoon, everyone. So today I will be talking about a patient case that deals with keeping in mind some pharmacogenetic considerations when we are dealing with a patient who has treatment-resistant depression. So the objectives are to define treatment-resistant depression, review some pharmacogenomics considerations for antipsychotics that are used in treatment-resistant depression, and then discuss a patient case where drug-gene interactions as well as drug-drug interactions may play a role. So treatment-resistant depression is essentially defined if the patient fails 2 or more adequate trials of antidepressants after they've been tried for an adequate period of time and at the optimized dose. And 34% of patients are actually not able to reach an adequate response to the antidepressants that are commonly used to treat depression. And as a result of this, treatment-resistant depression will often lead to a greater suicidal ideation and attempts when the patient is facing a depressive episode. So right now, the guidelines they suggest starting with a first-line antidepressant, such as the SSRI or the SNRI medications, up to the optimal dose for an adequate period of time. And then if there is no improvement seen within the first few weeks, then the patient can be switched to another antidepressant. And then if the patient still is not able to respond to 2 different antidepressants, then an augmentation strategy can be considered. And that usually means when you add an agent after a trial of 4 to 6 weeks, because the patient either partially responded to the first-line agents or did not mount an adequate response to the antidepressant. So these are the several commonly used antidepressants we have in the market. The SSRIs and the SNRIs are, of course, our first line. Then we can use bupropion or mirtazapine or use them as augmenting agents as well. The tricyclic antidepressants and the monoamine oxidase inhibitors are not used or preferred. So they are usually the last line just because of their side effects profile. We also have other agents with novel mechanism of action, such as vilazodone and nefazodone, that could be considered. As far as antipsychotics that can be used to augment another antidepressant in a patient with treatment-resistant depression. So the second generation antipsychotics may be effective for patients who either have had a minimal response to an antidepressant monotherapy or a partial response. But the dose used in such cases is often lower than we would use for a patient with bipolar disorder or schizophrenia. So the most commonly used antipsychotics of the second generation class for augmenting in depression is aripiprazole, quetiapine, and risperidone. And the doses are as seen in this slide. We do have to keep some pharmacogenomics considerations in mind for all 3 of them. So for aripiprazole, we have to keep in mind interactions with CYP2D6 inducers and inhibitors, as well as CYP3A4 inducers and inhibitors. As far as quetiapine, CYP3A4 inducers and inhibitors can affect its levels. And then for risperidone, CYP2D6 may impact risperidone levels. As far as the side effect profile for these 3 drugs, aripiprazole is not as much associated with different types of side effects as quetiapine or risperidone. But one side effect of aripiprazole is that it can cause akathisia. Whereas for quetiapine and risperidone, they are more commonly associated with metabolic abnormalities. So they can cause weight gain, abnormalities with glucose. They can increase lipid levels as well. And then with quetiapine, it also causes sedation to a greater extent compared to the other 2. And then with risperidone, it can cause elevation of prolactin levels, as well as cause tardive dyskinesia, dystonia, Parkinsonism. And then regarding anticholinergic symptoms, quetiapine causes anticholinergic symptoms to a greater extent compared to aripiprazole or risperidone. So if a patient is taking a concomitant CYP2D6 inhibitor or CYP3A4 inhibitor and is also on aripiprazole, then we might be concerned that they would have a higher likelihood of any of these side effects. So that's why pharmacogenomics would be important to keep in mind for these drugs, just because of their side effect profile. And also if they are taking other drugs that can inhibit their metabolism and increase the likelihood of side effects. And that ends my didactic portion. The next, I will talk about the case.